Well, hello everyone. It's great to be here. My name is George Waring from the Waring Vision Institute in Mount Pleasant, South Carolina. And we've had the distinct pleasure to get to work with the Pentacam AXL Wave for a number of months now. And this has really been an enabling technology that I'm very excited to kind of teach you about. So let's begin with some of the features about what makes the AXL Wave unique in our marketplace. First off, it's the patient flow. And when we think about this, we are looking to streamline our flow. We really want to optimize not only our time and our staff's time, but at the Waring Vision Institute, it's our client's time that's most valuable, right? So we really position the client experience first and foremost. So anywhere that we can get all the diagnostic information in a single device is useful. So we get the Pentacam AXL overview. We get the visual performance display for not only for patient education, but also for clinical decision-making, aberrometry with objective refraction and higher aberrations, and also cataract pre-op display and an IOL calculator, and post-op assessment in terms of how may things look once we're done. So this is, again, something new. This is all in one unit. This combines optical biometry, high-resolution tomography, and now Hartman wavefront sensors all into a single best-of-class device. So here's our full sequence overview, and let's have a look at this. We've got the total visual performance, which looks at external and internal optics to give us a visual representation of how our patients are seeing. We get iris image, both in scotopic and mesopic conditions, with a retroillumination image that gives us very valuable information on opacity and also lens position. And then as well as photopic. So we actually have different lighting conditions to capture this image based on how the diagnostic is acting. So very, very important. Now, moving over, we also get refraction data. So again, in a single diagnostic device, we're actually getting very reliable refraction, wavefront aberrometry, biometry, and tomography. Again, in a single overview with one device. We've never had this before, so very unique. So the question is, why is this patient not seeing well? Well, how does the Pentacam AXL calculate internal aberrations? Well, here's a great example looking at a stage 2 dysfunctional lens, or maybe somebody's just kind of crossed into stage 3. That's really the question. You know, is this somebody? Why are they not seeing well? Well, when we subtract external from internal aberrations, that is to say, when we subtract external from total, we get internal. Now I want to show you something that's very unique here. This is total eye aberrometry. Here we have total internal aberrometry, and here we have total corneal aberrometry, but including the posterior surface. This is unique in this device. It's unique in the marketplace. Why? This is unique because all other devices actually include the posterior cornea in internal aberrometry, and that's not the right way to think about this. When we're talking about internal optics, we really want to relegate that primarily to the lens. Yes, we're learning more and more that the vitreous may play some part in that, but it really should not include the posterior cornea. The cornea surface, anterior and posterior, really should be an external single unit that we want to be thinking about in terms of aberrometry and also refractive data and anterior and posterior keratometric data. So when we look at somebody who has post-RK, well, what would we anticipate? We would anticipate highly aberrated corneas, not internal aberrations necessarily. And that's exactly what this is showing here. So this shows us good quality crystalline lens internally, but poor quality external optics, right? And the total eye resultant aberrometry is not great. Now, where are some other etiologies of poor internal optics? Well, the displaced IOL. This shows with the retroillumination, again, which gives us great objective evidence in a scan. We now have a photo of the lens itself, that correlates beautifully with the source of aberration. So is this somebody who we want to refixate? Yes, I think that makes sense given the fact that it has a bearing on their internal optics objectively. Now, when we look at this in terms of other subtle things, like look at this, LASIK flap stria, this example, the question is, do we need to refloat this? Do we need to stretch and suture? Is this somebody who needs a therapeutic treatment? Well, how is it affecting their optics? Poor external optics. And now we can correlate it with the retroillumination. So we've got great evidence that helps justify perhaps another procedure. And so the question is, how do we want to use this to educate our patients? And we take people on an advanced vision analysis at the Waring Vision Institute. It's a digital tour of their eye, where now we have information that we can extrapolate and we can show. So here we have refraction, and this is a selectable diameter pupil. By the way, we all know that when we look at lower or higher order aberration profiles, this is pupil limited. So the pupil diameter is critically important anytime we're evaluating internal optics. And because again, this is it's a pupil limitation. So that's very important. But we actually get a printout of aberrometry on the map, and we could divide this out, the single aberrations of the total eye. And we can even simulate day and night, because we have control over the different pupil diameters. And that's very interesting. So we can look at mesopic versus photopic conditions depending on at what time point the image is being taken, and that's all automated for us. So very, very useful. This also allows us to evaluate the interplay with what I just described, the smaller effective optical zone versus a larger effective optical zone as it relates to aberrometry. Critically important when we are really teasing out how this is going to manifest itself. Well, what about the post-op assessment? Very interesting. We can now look to see, okay, not only what is our planning, but how did we do? That's kind of the future, is the data feedback as we look at our outcomes and we look to see, were we aligned? Well, what if somebody had a little bit of residual astigmatism? Well, the hope is that we're going to be able to take the retroillumination. Here we can see the toric hash mark to get a reference point for our intended alignment. And but when we look at this, we can actually look and see that we may have some residual cylinder. So we'll be able to correlate in the future the topographic overlay to understand exactly how did this patient do, and just another wonderful application for the future of this technology. And again, this is a little bit of a glimpse into the future of where we're hoping to go with this. It's also post-op assessment if we have some questionable rotation, which does not happen often. But I think a better way to say this is there some slight residual astigmatism after a toric IOL. So again, this is very, very neat stuff. It's almost like 5 devices in one when we think about this, right? But one thing from an efficiency standpoint, I just want to take one moment and speak to about also the IOL calculation part of this. It's very exciting, and also a little bit of what's coming. But this is what I want to talk about here, is the cataract pre-op display, and also how do we choose our IOLs? Well, we've got pre-op cataract screening, IOL selection, because now we have the ability to evaluate higher order aberration profiles and make good lens decisions based on the higher order aberration profile of the implant. IOL power calculation, and so on and so forth. So when we look at this, we also have the total corneal refractive power. So direct measurement of the posterior corneal surface, anterior corneal surface, so this accounts for both. Totally changing the game now that we're directly measuring the posterior corneal contribution, which we know is so incredibly important. But also other things like chord mu, which we described in the American Journal of Ophthalmology as a displacement from the patient-fixated in a coaxial sided light reflex and the center of the entrance pupil. All right, these are more clinically meaningful methods of understanding, hey, how are we doing with centrating our implants, or where should our lenses be centrated? As well as some things like pupil diameter in our different lighting conditions. So, and then of course, optical biometry, all integrated into a single image. But this is where this gets really exciting. This is all the contemporary formulae are already in here, including post-refractive calculators. And this has something very unique called the Holiday Report, which actually back calculates to estimate and calculate the preoperative refractive state without historical refractive information. Only device that we know that does that. So this is extraordinarily useful when we're trying to think about our post-refractive IOL patients. 40 million patients have had LASIK, right? So more and more of these patients are coming for lens replacement. So this is just really important. Plus advanced toric calculators that are helping us automate, measure directly anterior posterior corneal information, and showing us what the right power is, not only for the defocus, but also for toricity. So very, very exciting stuff. So in summary, in many ways, this represents the future of diagnostics. This represents the future of efficiency, workflow, and advanced thinking, because it's also patient education, and clinically, this educates you to make good clinical decisions too. Should we be doing an external therapeutic approach, an internal therapeutic approach? Now we have these overview displays, visual performance displays for patient education, aberrometry, built-in direct measurement with Hart-Shachtman wavefront sensors, and then IOL calculators with optical biometry. And here's kind of where we're going in the future is post-op assessment. How did we do and why if we were off? So very, very exciting stuff. So with that, again, it's just our real pleasure to get to speak to you about this today. We couldn't be more excited about having access to this type of technology, and this company is really dedicated to thinking and creating the future. So we actually have a lot more to look forward to. So stay tuned, and thanks so much for your time and attention.